Hello and welcome today to the British Liver Trust webinar, Life After a Liver Transplant. It's really great you could join us today, so thank you very much for attending. Today's webinar will be aimed at individuals and their families as well who have recently been through a liver transplant and also those waiting to receive a new liver in the near future. So we'll take away an insight today into some of the milestones that you've reached post-transplant, how to manage taking your medications every day, how to keep yourself well post-transplant, and to provide some insight into the types of support that are available to people throughout the transplant process. I'm going to pass you on to my colleague Amy right now, who's going to run you through the agenda for today.
Thank you, Kenny. Hi, everyone. Thank you for joining us this afternoon. So we have a number of speakers for you today from across transplant units across the UK. So you will hear from Dr. Victoria Appleby, who is a consultant hepatologist from Leeds. She will talk through some of the milestones you will reach post-transplant. You'll hear from transplant pharmacist Louise Hogg, who's going to talk through some of the medications and how to manage those once you're post-transplant. You will have a session from Fiona Dawson, who is a social worker from the Scottish Liver Transplant Unit, and she's going to talk through some of the support available to patients and families through the transplant process. You will also hear from a patient speaker, so Murray, who's been through the transplant process himself, and he'll be able to share his story with you today. And finally, we will have a Q&A session at the end with the panel. So just to ask everybody who's here today, rather than have your questions at the end of every session for the speakers, please use the Q&A box that is provided on the bottom of your screen, and you can add questions throughout the webinar today. We'll do our best at the very end to answer as many questions as possible. And after we've heard from all our speakers, just to make sure that we're not answering any individual queries, they're more generic questions. So we do advise you to go back and speak to your own clinical team if you have a specific question after today's session. Over to Kenny.
Thank you very much. So without further ado, it is my great pleasure to welcome consultant hepatologist Dr. Victoria Appleby.
Thanks, Kenny, for the invite to talk. So I'm going to cover some of the common things that happen after liver transplant. I've got a couple of slides. I think the first thing to probably say is that this list isn't exhaustive. I would echo what Amy said. Any specific questions, go to your unit, they'll be able to answer everything. And from working at Leeds, we're always more than happy to field any questions. And if we can't answer it ourselves, we always go and speak to colleagues or other members of the team. So I'll just try and share my screen now. So, I'm Victoria Appleby. I'm a locum consultant hepatologist and I work in Leeds. So a quick overview of the session. So what I'm going to try and cover in the next couple of slides is what to expect in the immediate post-operative phase and a little bit about recovery. I'm then going to touch on what happens when you leave hospital after transplant. I'm going to leave medications and immunosuppression to my colleague Louise. I'm going to talk a little bit about vaccinations, about travel, some generalised dietary considerations, a little bit about alcohol, and then finally exercise, the transplant games, and trying to return to life after transplant. So I think the most important thing to recognise is that everybody's recovery is individual. So don't compare yourself to other people that you may meet through support networks or to other people on the ward. Once you step down from the intensive care unit into the ward-based environment, we try and get you out of bed as quickly as possible. I'm going to talk a little bit about the wound in the next slide and a little bit about the drains. But when you come back from the intensive care unit onto the ward, you'll have a wound which is covered with a dressing, and you'll often have between 2 and 4 drains in the abdomen. They stay in for differing lengths of time depending on whether you had fluid in your abdomen prior to the operation and how much fluid is produced after the operation. So we try and get things out as quickly as possible, but obviously if you're staying a little bit longer than you'd expect, that's not a worrying sign. When you come back to the ward, you'll have a catheter, which helps obviously with the passage of urine, and you'll have one of the catheters, one of the cannulas in one of the veins in your neck. So what we try and do at Leeds is get rid of things like the catheter and the central line as quickly as possible, because you start to feel a lot more human as tubes get removed. So once you're back on the ward, we depending on how your operation has gone, we get you eating and drinking fairly quickly. We obviously take advice from the surgeons, and depending on the complexity of the operation, sometimes it may be a day or two before we can introduce solid food. If that's the case, then we may try to supplement your diet with things like nutritional supplements, like the fresh bin in the picture below. And some patients need a period of NG tube feeding. So this is a small flexible tube which is passed from the nose into the stomach and helps with additional feeding, because we know that good nutrition helps with wound healing and helps with getting people out of hospital quickly. Lots of patients that I see when I'm on the ward complain of ankle swelling, and this is quite normal. So surgery is a huge insult to the body, and the protein level in the blood drops, and so fluid can leak into what we call the third space. So this is your ankles and into the abdominal cavity as well. So once you're up and moving, and the liver's working well, and you're recovering from the surgery, that ankle swelling will usually resolve of its own accord. In some cases, we can think about a little bit of water tablet to try and help, but generally it just resolves as you get better and start moving around. And then you'll notice that we take lots of bloods when you're back on the ward. So we tend to do bloods most days, and that's because it's the best way that we can look at how the liver's functioning. We can pick up for subtle signs of infection, so we can be very proactive in terms of trying to identify something that might cause a problem. So these are the two most common surgical scars which are associated with liver transplant, and the one on the right, which I describe as a reverse hockey stick, is the one that's most often used. The one on the left, which often looks a little bit like the Mercedes-Benz scar, was used more historically in liver transplants, but ultimately the surgeon will do whichever incision is needed to be able to get the liver out and to be able to put the new liver in. And as you can see, these are older operations, so the scars have healed really nicely. But obviously, what I would say is be proud of your scar, because it shows what you've been through and the journey that you're on. So when Amy talked about trying to identify milestones, I think the first one probably would be going home. Probably this should be the second, and the first should be coming back to the ward from the intensive care unit. But let's say the first big milestone is leaving hospital. And I think it's completely normal to be quite anxious about this. It's obviously a team decision when we feel somebody's ready to go home, and within that we take into account how you feel and how your relatives or next of kin feel as well. But the anxiety is normal, it's to be expected. It's almost like when people leave hospital with a baby for the first time, it's suddenly like, do I know how to manage this? But what we do is we give you exhaustive lists of phone numbers for support, phone numbers for the ward, for the transplant coordinators. And in all units, there's a doctor on call 24 hours a day. So no query is too small in terms of if you're concerned about something. We would much rather you picked up the phone, because in most cases we can alleviate any concerns that you have. But also if you have something that we would like to take a bit more, look at in a bit more detail, it's useful that you let us know. So I've identified milestone 2 as being leaving the immediate post-transplant clinic. So in Leeds, and other units may differ, patients are reviewed in the surgical clinic for 1 to 3 months after their transplant. So it's very frequent reviews. In Leeds, we see patients usually weekly, and then as they're approaching the 3-month point, we may reduce those visits to fortnightly. Again, lots of blood tests whenever you come to clinic, and that's because, as I said earlier, it's the best way that we can work out how the liver's functioning. So I'm just going to take this opportunity now to talk very briefly about rejection, because I know when I speak to people on the ward and in clinic prior to their transplant, this is the thing that concerns people the most. So rejection is a very scary word. It makes people worry that they might lose the liver, or that the liver might not work properly in the future. What I would say is that rejection is very common, and when I consent people for liver transplant, I say it's as common as 1 in 3 people will have some problem with rejection. So Louise will talk a little bit about the medicines that we use to try and prevent that, but ultimately we do bloods to find it, because if we can find a problem, then we can treat it. And it's only when rejection isn't identified or isn't treated that it means that the liver may lose function in the longer term. So in terms of treating rejection, sometimes we can do it as an outpatient just by changing the medicines that you're taking and the doses, or sometimes you need to have a short stay in hospital for some stronger medications through a drip. it's very common in the first 3 months after transplant to change the medications, which Louise will touch on. So don't always panic if you hear about changes, because ultimately when you first leave the hospital, that's when you're on the largest doses of immunosuppression, when the transplant is in its infancy. And the further you get out of transplant, we try and change those medications to reduce the tablet burden that you have. Also, during these clinic appointments, there'll be the opportunity to have a look at your wound, discuss how you're getting on, exercise, functioning, and any concerns which have arisen between the reviews in hospital. So looking forward to the future, because I think this is the most important thing, because the reason that we recommend transplant and that we all work in transplant is that we want to treat liver disease, and we want to prolong life expectancy in patients who have liver disease, and we want people to return to a normal life. So given that we've all been locked down and in some cases isolating for large periods of 2020 and 21, the thing that's on everybody's mind is travel. So we try as best as possible to facilitate travel for patients after they've had liver transplant. But what we would say is we really want to know when you're planning to go away, and even that's if it's to the other side of the UK. So definitely let us know. We'll also be jealous if it's somewhere far flung. What we tend to say for the first 6 months after liver transplant is that we only recommend travel within Europe. And like I said, depending on how you get on after your transplant, sometimes we say usually within Great Britain. But if you're clinically well, there would be no reason to not think about going to mainland Europe. Further away, so more exotic destinations, we don't tend to recommend for the first year after transplant, just because of things like vaccinations and access to medical services whilst away. But general considerations when you're thinking about going away, even if it is just to somewhere else in England, you need to have a plentiful supply of your medications, and you need to have knowledge of how to access medical services where you're choosing to go. So touching very briefly on vaccinations, once you've had your liver transplant and you're immunosuppressed, live vaccines are contraindicated. Now, the list of vaccines that people are offered at different points in their life is quite exhaustive. So what I would say is common vaccinations, so flu, now COVID, and the pneumococcal vaccine are all safe. And what I would say is whenever you're offered a vaccine, if your GP isn't sure, or if you're not sure whether it's live or dead, let us know and we can advise it accordingly. So moving on to food and alcohol. Now, when you're in the hospital, either before the operation or after the operation, you have free rein to consult the dietitians. So I'm just going to touch on some very general principles. So after liver transplant, we recommend that you avoid shellfish and undercooked pork products, and that's because of the risk of developing hepatitis E, which can be very troublesome to treat in patients who've had liver transplant. I generally live by this rule, but I would say exercise caution at buffets, deli counters, and pick and mix counters, mainly because you don't know who else had contact with the food, so the risk of picking something up which may lead to a GI upset. And that's the major concern that we have, because if you have gastrointestinal disturbance, diarrhea and vomiting, it can be very difficult to take your medications and for your body to absorb those medications so that they can do the jobs that they're tasked to do. We recommend that you wash all fruit and veg, and when you're defrosting produce from your freezer, you defrost it once and then it's cooked, and you don't either try and freeze it again or wait for a prolonged period of time before cooking it. Make sure your fridge is clean and at the correct temperature. We don't recommend that you wash any poultry. It's safe in the UK to cook poultry without washing, and we also are concerned that any bacteria that are there that would be killed during the cooking process would then contaminate things around the sink, so things like other crockery and cutlery and work surfaces. We don't recommend that you eat rice that has been cooked and then left around for a long period of time, and definitely never reheat rice. And when you're venturing outside of the UK, we would always recommend that you drink bottled water. In terms of alcohol, this will have been covered as part of your assessment, but if alcohol has at all contributed or caused liver disease, we would at Leeds, we recommend signing a no alcohol for life contract. And for individuals where alcohol hasn't contributed to liver disease, we know that alcohol can cause more damage in the transplanted liver. So we whilst we don't say no alcohol, we say very occasional use and just 1 to 2 units maximum. So in terms of exercise, we're all very proactive in terms of recommending exercise. If you're currently on the waiting list and waiting for transplant, I'm sure it's mentioned at every clinic appointment that you go to. And afterwards, we recommend exercise because it keeps you well and helps with the recovery process. But for the first 3 months after transplant, we would say avoid heavy lifting, strenuous DIY, which some people may use as an excuse to never go back to DIY, or excessive abdominal exercise, just because of the fact that you've had quite extensive surgery there, and avoid contact sports. I think walking is excellent, and it's a really useful way of being able to track your progress, either looking at it in steps on your iPhone, or time out of the house, or distance. You can see an improvement by walking. And if you're a keen athlete prior to transplant, we would definitely be interested in you representing your unit at the transplant games. And if you're on the Leeds waiting list, mention it at your next clinic appointment, because it's going to be hosted in Leeds next year. So I think in summary, what I've tried to get across in the preceding slides is that the aims of transplant are to treat liver disease and to prolong life, but more importantly, to try and restore a normal life. Whilst we may say it's the new normal, I think that's what we all endeavour when we sort of embark on transplant as a treatment option. And I'll leave it there for today.
Thank you very much for that really insightful and informative session, Dr. Appleby. That is absolutely brilliant. Anybody, if you've got any questions for Dr. Appleby, please put them in the Q&A function at the bottom of your screen. I will come to them at the end of all of the sessions. I would now like to introduce you to Louise Hogg, who is an advanced clinical pharmacist, also from Leeds Teaching Hospital. So she's going to speak to you about medications and what you should expect post-transplant. So I'll hand over to you now, Louise.
My name's Louise, and I'm one of the liver pharmacists at Leeds Teaching Hospitals. So my plan for this part of the webinar was to kind of talk about what immunosuppression is and give a little summary of the different types of immunosuppression that you might be on after a liver transplant, and then touch on medicine supply, compliance, and tips to basically help you to be able to remember to take your medicines, and then a little bit about herbal medicines. So immunosuppression. So obviously are going to have or have had a liver transplant. How your body sort of reacts to something that it sees as a foreign object is to kind of attack it, for want of a better word. And this is a normal response that helps us stay healthy and fight infection. But after a transplant, your body basically sees that new liver as a foreign object, and so your immune system basically tries to attack it, which is basically what rejection is. So to prevent this from happening, you will be taking anti-rejection medicines after your transplant, and these are also called immunosuppression or immunosuppressants. So you will be on some form of immunosuppression for the rest of your life, but as Dr. Appleby already kind of mentioned, the amount that you're on, we aim to reduce that over time. So how they work, so they suppress your immune system, so that reduces your body's ability to be able to fight infection. So there are some general kind of considerations that you need to follow after transplant. So you will be more susceptible to kind of picking up infections. So what we would advise is to try and avoid being in close contact with people who have coughs and colds or other types of infections. Being on immunosuppression also increases your chance of developing certain types of cancer, including skin cancer. And so whatever sort of liver transplant center you're linked to will give you safety advice on protecting yourself from the sun and on how to basically examine your body. But overall, the benefits of being on immunosuppression far outweigh the long-term risks. So yeah, I'm basically going to run through all the different types of immunosuppression. You won't be on all these, but it's just kind of to make sure I'm covering all the bases for everyone. So the first medicine is called tacrolimus. So the most important thing about tacrolimus is that it's brand specific. So you should be on the same brand, and the only people that would change the brand that you're on would be your transplant centre. So it's important that you check tacrolimus at roughly the same time each day, and that'll either be once a day or twice a day, depending on the preparation that you're on. If possible, it's best to take tacrolimus on an empty stomach. However, that doesn't agree with some people, so some patients find it easier to take with food, and that's fine. I guess the most important thing is that you take it at the same time in relation to food each day. The main side effects of tacrolimus are that it can alter your kidney function, which is something that we keep an eye on anyway. It can cause hair loss and high blood pressure and high blood sugars. Tacrolimus, the dose that you take basically depends on the level in your blood, and we check that level when it's at the lowest. So just before you're due to take a dose, if that makes sense. So on the days that you're coming to clinic or having your bloods, don't check your tacrolimus before you come to clinic. So cyclosporin, so you'd either be on tacrolimus or cyclosporin, not both, just to clarify that one. Again, it's brand specific, so it's important that you remain in the same brand. And the most common brand that people are on is called Neoral, and that's taken twice a day. And again, take it at more or less the same time each day if you can. And it's another one where we check the levels. So on days that you're coming to clinic, don't take your cyclosporin before you come. And the main side effects include, again, altered kidney function, hair growth, high blood pressure, swollen gums, and high blood sugars. Also, with both tacrolimus and cyclosporin, different medicines can basically interfere with the levels of those types of immunosuppression. So if you're starting any new medicines or you buy any new medicines from your pharmacy or anything like that, just make sure with your transplant centre that it's okay for you to have. The main drugs that can kind of affect the levels are, so there's certain types of antibiotics called erythromycin and clarithromycin. Anti-inflammatory medicines like ibuprofen and diclofenac, and then certain types of antifungals as well. And we also say to avoid grapefruit or grapefruit juice because they can also affect the levels of tacrolimus and cyclosporin. If you do forget to take a dose, so if you're on a twice a day preparation of either of these drugs, we have what we call a 6-hour rule. So if you remember within 6 hours of when you usually take it then when you remember, and then take the next dose at the usual time, if that makes sense. And then if it's a once a day preparation, we have a 12-hour rule. So if you remember within 12 hours of when you usually take it, then you can take it then when you remember, and the next dose at the usual time. If it's over 12 hours, then just miss that dose and take the next one at the usual time. So basically, never take a double dose to kind of make up for a missed dose. So the next type of immunosuppression that you might be on is called mycophenolate. And just to note that there's two different preparations. So either mycophenolate mofetil or mycophenolate sodium, which is like an enteric coated version. So you can have any brand as long as it's correct version, so mofetil or sodium. So different variations of mofetil, like different brands, you can switch between any of those, if that makes sense. Mycophenolate's usually taken twice a day, so every morning and evening, about 12 hours apart. And again, it's ideally best to take on an empty stomach, but again, some people tolerate it better if they take it with food, so that's fine. Again, just make sure you're taking it at the same time in relation to food each day. And so side effects with mycophenolate, so it can increase your risk of infections, and it can cause some stomach upset, but there are things that we can do with the dose, or switching to the different type of mycophenolate to kind of help with those stomach issues. So just let us know, or let your transplant centre know if that's an issue. In terms of other medicines that can affect mycophenolate, so there's certain medicines can basically reduce the amount of mycophenolate that you absorb. So if you're on like Gaviscon or an iron supplement, just make sure you leave a 2-hour gap between your mycophenolate and that. And again, just check with your transplant centre if you're starting any new medicines, so that we can check they're okay with your liver medicines. And for mycophenolate, again, in terms of missing a dose, we have that 6-hour rule, and don't take a double dose to make up for missed doses. Another thing to note with mycophenolate is that it's not recommended in pregnancy. So each transplant unit will have advice for you to follow regarding appropriate contraception if you're on mycophenolate, and that's both for males and females. And if you are planning a pregnancy and are on mycophenolate, just speak to your transplant centre about that. So the next one is azathioprine. So again, mycophenolate and azathioprine, you either be on one or the other of these, not both. So azathioprine you take once a day. It's not brand specific. It's usually better to take azathioprine after a meal so it doesn't upset your stomach. And in terms of other medicines that can interfere with azathioprine, the main one is allopurinol, which is a drug normally used for gout. So if you are on allopurinol, please speak to your transplant centre about that, because you'll need a much lower dose of azathioprine, and ideally want to avoid the combination altogether. If you miss a dose of azathioprine, the 12-hour rule applies here, and you shouldn't, again, take a double dose to make up for any missed doses. And in terms of side effects, again, infection risk, an upset stomach, and hair thinning or hair loss. So the next type of immunosuppression is prednisolone. Some people might be on this already prior to transplant. But after transplant, usually you're only on it for kind of a couple of months after. But some patients, depending on the reason why they're transplanted, might continue on a small dose longer term. With prednisolone, you take it once a day. Again, take it at the same time each day. And the best time to usually take a steroid is in the morning, as it can disturb your sleep if you take it too late. Steroids can upset your stomach, so best to take them with or after food. And other side effects include swollen ankles, acne, weight gain, and high blood sugars. With steroids, you shouldn't stop taking them suddenly. It's usually something that needs to be weaned down. So yeah, don't stop them suddenly without speaking to your transplant team first. And everyone who's on steroids should get like a little blue steroid card. And what we say is normally pop that in your wallet or in your purse, and show it to any healthcare professionals treating you, as depending on what you need to do and why they're seeing you, they might want to know that you're on steroids. And so the last type of immunosuppression that I wanted to touch on is called sirolimus. And you take sirolimus once a day at the same time each day. One thing to note about sirolimus is that the 0.5 milligram strength tablets aren't chemically the same as a 1 milligram and 2 milligram strengths. So for example, if your dose is 1 milligram and you usually take the 1 milligram strength tablets, but you run out, you can't take 2 of the 0.5 milligrams to make that dose, if that makes sense. Common side effects include swollen ankles, hands and feet. Again, it can upset your stomach. Some people complain of mouth ulcers, so there's certain things that in terms of oral hygiene that you can do to help prevent those if you're on sirolimus. And then acne and high cholesterol are other side effects to note. And also sirolimus can delay wound healing, so it wouldn't sirolimus wouldn't be something that you put on immediately post-transplant. This might be something that you're sort of switched on to later down the line. So after transplant, if at any point you are put on sirolimus and you're due to have any other surgery, just make sure that you inform the relevant surgeon that you're on sirolimus, because there might be things that they need to do around that. Yeah, and I think, yeah, that's all the immunosuppression covered. So next, I just wanted to talk about medicine supply. So usually immunosuppression, apart from prednisolone, comes from your transplant centre for the first 3 months after transplant. And then at 3 months, we ask your GP to take over the supply. And for certain reasons, sometimes GPs aren't able to take over the supply. So I guess the main thing to say is don't worry about that. Your transplant centre will make alternative arrangements if that's the case, so you will always get a supply of your medicines. For prednisolone and other sort of supportive medicines that you'll be put on after transplant, your transplant centre will send you home with a good supply of those, and then we write to your GP to explain all the medicine changes and ask them to sort of supply them going forward as per the usual process, so getting them added onto your repeat lists, and then you just request your prescriptions in the usual way. If you do pay for your prescriptions, a prepayment certificate usually works out to be the cheapest way to do it, so that's just something to note if you do pay. Then in terms of compliance, so obviously your immunosuppression does a really important job in terms of preventing rejection after transplant, and they are really important medicines to remember to take. There's various reasons that people can sometimes forget to take their medicines, and if that is an issue, I would just definitely encourage you to speak to your transplant every transplant centre has a liver pharmacist, so please talk to them if you are struggling to take your medicines or you think that'll be an issue, because there are different things that they'll be able to do to help you with that. Certain things that might be suggested are a kind of weekly pill box or Dosset box or a compliance aid. They're all basically different variations of the same thing, where all your medicines are popped out into a little tray for the week. So some people find that useful. You can set reminders or alarms on your phone to remember you to take them, and there's certain apps you can download on your phone. I think one example is called MediSafe, that lots of people say is really good to help in terms of remembering you to take your medicines. The most important thing is basically to find your routine that works for you. So obviously in hospital, you might be given your medicines or prompted to take your medicines at a certain time, but if those times don't work for you, then when you go home, then just switch things about. As long as you're leaving roughly a 12-hour gap between the twice-a-day medicines, and you can alter the times if that makes sense. Just find a routine that works for you, and yeah, speak to your liver pharmacist at your local transplant centre or your community pharmacist if you're sort of struggling with remembering to take your medicines, because they'll be able to help. And the last thing I wanted to just mention was about herbal medicines. So in general, we do not recommend that you take any herbal medicines after a liver transplant. These medicines don't go through the same kind of rigorous regulatory process that that licensed medicines do. So we can never be sure that they're not going to interfere with your liver medicines or cause any kind of liver problems. So that's kind of why we say it's best to avoid these types of products. And yeah, that's it from me. And then I think we're just doing any questions at the end. So just pop them into the Q&A if you do have any. Thank you.
Thank you very much, Louise. That was fantastic. Thank you very much. I'd now like to introduce Fiona Dawson, who's a liver transplant social worker at the Edinburgh Transplant Unit.
Okay, thanks for inviting me to take part in this webinar today, and thank you to the previous speakers. It's been really interesting hearing from you both. My name's Fiona Dawson. I'm a social worker at the Scottish Liver Transplant Unit in Edinburgh, and I'm here today to talk about what support social work can offer and does offer post-transplant to patients and families. When a patient has undergone a liver transplant, normally I would have had quite a bit of contact with that patient and their family prior to them coming in for their transplant, normally during the assessment week. So from the assessment week, I'll have already built up a good relationship with the patient and the family, and kind of, you know, when they come to clinic, contacting them, calling them, just, you know, supporting them while they're on the waiting list. So by the time they have come in for the transplant, I'm in a good position to offer emotional and practical support to the family while they're going through that stress of waiting for the person to come through their operation. Now, living in Scotland and Edinburgh being the only transplant centre in Scotland, we do have the additional issue of it's quite a lot of travelling for patients and families. Often patients come down from the Orkney Isles, north of Scotland, so there is a lot of travelling. Therefore, often when patients come in for transplant, they can be separated from family members and their carers for quite lengthy periods of time, which can be difficult. Is difficult, and obviously sometimes the only link they've got between the family and the hospital is the social worker. So as I say, prior to coming in for transplant, it is very important that the social worker builds up relations with the family and the person so that they've got a direct point of contact to come to post-transplant. What I always say to my patients when they come in for assessment is that after the transplant, that's just the start of the journey. So, you know, you don't get a transplant just to sit and then that's it. You know, you're a person, you're a wife, a husband, son, daughter, you know, you're the whole person. You've got a life and you have this transplant to live your life and enjoy your life. But obviously you may have had a period of being really unwell and, you know, being prevented from doing things, participating in family life, work life, normal day-to-day life. And it's a huge adjustment coming through that period when you do have a transplant and you're kind of on the next journey of being, you know, progressing to being well and starting to adapt your life as the person who is now post-transplant. Now, obviously, it's a, you know, it's a very positive thing having a transplant. Hopefully, all going well, you're going to have a good recovery. But like previous speakers have said, everybody's different. Everybody's on their own journey. But you know, there is a lot of adaptations to be made, and it's not just a, you know, you have your transplant, that's it, you leave, you're discharged, and that's it. There's a lot of adaptations to be made and adjustments, and this can take its toll emotionally on a person. And the social worker is there to support that person through these changes and speak through any difficulties they may be having in coming to terms with they've been through such a major operation, and looking at, you know, how they move forward post-transplant. Also for the carers, the social worker works very closely with the carers, whether that's a wife, husband, son, daughter, mother, father, partners, you know, whoever is the person's significant other, because the carer is the person that is there throughout, who is sort of standing out, looking in, and not having any control or saying what's going on. And it's very worrying and stressful for them, because as well as the patient, they're worrying about their loved one, they're also carrying on with normal life, such as work, dealing with finances, housing, childcare, just the day-to-day life, so that when the person does come through the liver transplant, then, you know, they've got their old life to go back to. So supporting the carer is very, very important. And I work very closely with carer support teams throughout Scotland that I can refer people onto for local support. And also we do have a carer support worker based in the Royal Infirmary in Edinburgh, who works very closely with people who are in a caring role for a person who's within the hospital in Edinburgh. So that applies to all transplant patients and their families throughout Scotland. So supporting the patient and the carer post-transplant involves many things. It's seeing them when they attend clinic, it's helping them adjust to this new life, helping them with finances, making sure they're getting all the benefits they're entitled to, and if not, how can we rectify this? It's looking at job opportunities for them if they've not thought about this, education opportunities for younger people who have, you know, maybe had a transplant and they've been unwell for lots of their young life. So it's, you know, it's a holistic approach social work takes in the transplant journey. And from the point of assessment, the social worker will have already built up a very close and supportive relationship with the patient and their family. So post-transplant, hopefully the patient will feel able to talk to the social worker and able to confide in them if they feel that they're needing support with anything. This takes me on to the support groups that we run. We run Living on the List pre and post support groups in Scotland, and I run them myself. I'm involved with them in conjunction with Amy from the British Liver Trust, and they began in Scotland to support people who are waiting on a transplant and post-transplant. Now these support groups now run every 6 weeks in Edinburgh, actually no, every 4 weeks, and we also run other groups in Glasgow, Aberdeen, Inverness, Dundee. These are all the outreach groups. They've all started from the Edinburgh group. And from these support groups, people are able to get peer support, which I can't state how valuable this is. Nobody knows better what somebody is going through and how to support them than somebody that has been through it or is going through it themselves. People from all different walks of life are thrown together in this very stressful event, and I always say the transplant support group is like the club that nobody wants to join, but once they've joined it, they don't want to leave, because the support that they get from each other is invaluable. And again, this applies to carers. I've seen a lot of wives or husbands link up with other wives and husbands who have been through supporting a spouse, and the support that they can give each other is, as I say, I can only use the word, sorry to keep using the word invaluable, but that's all I can think. From the support groups, patients themselves develop relationships with each other. So there's some patients have formed their own personal links with each other through WhatsApp groups or meeting up. And again, this is really important, peer support. I can't emphasize the power of peer support. Research has proven that this is invaluable, but actually me experiencing it myself, seeing how the patients support each other, it's really humbling to see how they support each other through this process. The support groups have been online since the start of the pandemic, which has been a lifeline for the patients, but it's difficult not having seen people face to face, but hopefully the support groups will get back to face to face. But again, these online support groups have given people a link to get together, speak, and feel supported at times when they may have been at home isolating on their own, feeling very vulnerable, just the news pumping out information that they don't know what's going on. During the height of the COVID pandemic, again, the role of the social worker was particularly important, because patients were coming in for assessment and transplant without any family support, which was just brutal. I can't imagine coming in for any procedure, medical procedure or assessment for any kind without the support of family or friends. And this is what the patients had to go through. So the role of the social worker was extremely important, because the social worker was the link between the patient and the family out with, and this was particularly important post-transplant. You're having patients coming from just having their operation, going into ICU, not having their family with them, then coming back to the ward. And it was very, very difficult for the families to imagine how their loved one was, and knowing that they were okay and they were getting through this traumatic period. So I would phone family members, liaise with them, ensure that the patient's okay. If they needed anything, something as simple as getting a patient a daily newspaper every day could mean the difference between them having a fairly awful experience, feeling isolated, scared and alone, to just having these little things that makes things just a little bit better, and somebody to talk to it's not just all about the medicine, the operation, somebody just to have a chat to, a coffee with, that's linked in with the outside world. The support that social work offers during the waiting list time, assessment period and post-transplant, the list isn't exhaustive. It's amazing what issues can crop up. It can be from support with getting an animal looked after while they're in hospital, to carer support. The person who's had the transplant or is waiting in the transplant could be the main carer for somebody who has got difficulties of their own. It could be physical disabilities, anything. So we really support with all aspects of this, and work very closely with local services to ensure that when the person goes home, they are practically supported, and the support, if required, is in place as and when they need it. We're all human and things change. As the doctor has said on here, people may have to come back in and out to hospital. We don't know what's going to happen with this new organ, but people's personal lives change as well. And a person can change after they've had a transplant. They may have a new look in life. The role changes. They've been the person that may be cared for to the person that no longer needs cared for. So there's a lot of supporting the patient and their families and their loved ones through adjusting to these new roles and new lives. So as I say, the list's not exhaustive. Basically seeing the patients at clinic is a good way, twice a week I attend clinic, is a good way to keep up to speed with people on and how they're doing. But also the patients always have the social work number, they can call once they've been in, that's them. They're as I say, they're in this club for life. They might not want to be in it, but they're in it. And anything at all, you know, they can pick up the phone or email myself and or somebody in the unit and ask to speak to me, and I'll be available. I can't really think of, I mean, I could go on and on and on about what we do, but basically I'm just here to offer the human aspect of support and the practical stuff that maybe, you know, the medical side of things doesn't do, because they're busy dealing with, you know, sorting out the body and getting that person well, and I'm here to support them and build up resilience and support and getting them emotionally and mentally well to just get back out into the world and lead a fulfilling and productive life. And that's, yeah, that's what I do. So I hope that's okay. Sorry if it's a bit short, but thank you.
Brilliant. Thank you very much, Fiona. And thank you for your continued support in helping to run and facilitate the support groups, and you've championed them from day one, so we're very grateful. So thank you so much for everything that you do for us and for the patients as well. So thank you, Fiona.
Thank you very much. Thank you.
And finally, I would like to introduce you to Murray. So Murray is a post-transplant patient, and he is going to share his experience of his journey of receiving a liver transplant. So Murray, I'm going to hand over to you.
Thanks very much to the aforementioned speakers. Brilliant information. Like most people, my liver journey began with just regular visits to the GP. Just lethargy really was my main symptom at that time. I felt generally unwell, and nothing seemed to work to resolve any issues that I had. So eventually I was referred to the GI unit in my local hospital, where again, eventually I was diagnosed as having non-alcoholic fatty liver disease, which was great in many ways, but at least I had a hook to hang my problems on and start to attempt to rectify them. Unfortunately, the disease that I had was too far advanced. I was stage 3 cirrhosis at that time, which very quickly developed into stage 4, and my liver completely decompensated. So at that time, the lethargy continued. I was very jaundiced. I had ascites, which needed drained very, very frequently. And I had also encephalopathy, which was not a pleasant experience to go through. So I was referred to the National Transplant Unit, where Fiona works. I went in for an assessment for a week, and there I met other liver patients for the very first time. And that was a bit of a revelation, because up until then, my world was non-alcoholic fatty liver disease, or NAFLD. There I met patients with every type of liver disease, and I soon realised how vast the subject, the whole issue is, and how common it is as well. So during the assessment week, I had lots and lots of tests, X-rays, CT scans, cardiac functions, lung functions, etc., many blood tests, basically to make sure that I was fit and well enough to actually go through a transplant operation. And indeed, if that was what was required for me at that time, the best appropriate way forward for my disease. In some, it's not. So, and the preparation that I had during that week, particularly little booklets that I got explaining everything, and the people that I met in there, including social workers, dietitians, the doctors, etc., it was invaluable. It put my mind at rest that I was dealing with people that were professionals in their field, and they knew exactly what I was doing. I was really greatly reassured there. After the assessment week, I was offered a transplant, or offered to go on a transplant list. So after a weekend thinking about it with my family, very important in the whole of this process is your family, we decided to go ahead. Really, there was no options. It was that or nothing. And it was a very bleak future if I opted for nothing. So very, very unusually, almost uniquely in my experience, 24 hours later, I got the phone call from the coordinators, 4 o'clock in the morning. I was told there's a liver going to be available So make my way to the hospital, don't break any speed limits, and do not go through red lights. We need you there in one piece, which was fine. The roads were quiet in the middle of the night anyway. So I had some more minimal tests, and then I met the surgeon and the anaesthetist, we were brilliant people. Again, they went through everything that I was going to go through. I had a few questions for them, which they answered very, very quickly and very, very accurately, as well, as it turned out. And as it turned out, the liver was compatible. So I have the experience of many people going to the hospital, getting prepared for the liver, and it wasn't compatible, and they had to go home again. So that was something that I was told to expect, and it didn't happen in my experience, but I know it can happen. So while I was waiting for the transplant to go down there, I was really quite excited at the prospect of better health at the end of it. I was nervous because, as the previous speakers have already explained, it's a big operation to go through. It's a huge event in your life. And also I felt sadness because somewhere in the country, someone's family has got a bereavement to deal with. And that played on my mind a little bit, but they've obviously agreed to this transplant, so I felt, it was better to go through with it. So I came round from the operation, felt no pain. I had all sorts of tubes in, some of them in existing orifices, some brand new ones. As the doctor said earlier, I had a central line in my neck, which was quite uncomfortable. It wasn't painful at all. None of the drains and things are painful. It was just uncomfortable and unwieldy. But you get used to things like that. So I had 2 days in the intensive care unit when I woke up, and really the only issue I had was a sore throat from the ventilation tube. None of the tubes were put in prior to me going into the operating theatre, and all the ventilation tubes down my throat were taken out after before I was conscious again. So it was not scary at all, absolutely not. So the only pain relief I had was what they call a PCA, so patient-controlled analgesia. So a little pump, it gives you a little shot of morphine, and I emphasise little. You can't overdose on it. And actually, I got a row for a while. I wasn't using it enough. But there you go. So after a couple of days to make sure that I was stable from the operation itself, things were going reasonably well. I was transferred to the high dependency unit. But the monitoring is just a little bit intense than in intensive care unit. Still lots of people around keeping an eye on you, but not the one-to-one monitoring that you get in intensive care. So a couple of site drains were adjusted and removed. I had a shower for the first time, which made me feel a lot better. I was encouraged to get up and be mobile a little, which was difficult, I would say. I had a hernia repair at the same time as my transplant operation, so I was quite stiff and unwieldy in my stomach area. But again, it was to be expected, and the nurses were just absolutely superb. They've seen it all before and knew exactly what to do to help me get through that. So after a couple of days in high dependency, I was moved back up to the liver ward, same ward as I was in when I was admitted a couple of days previously, which is fine because it was a familiar environment and the nurses there were still the same ones, and that was great as well. I think they were glad to see someone come through the operation, at least I felt they were, because I got a good welcome in there. So again, encouraged to be even more mobile as much as I can, or as much as I could. I took daily showers. I was encouraged to get up and about, and slowly the tubes and the drains were gradually removed. And the big event, one of the milestones, in any journey there are bumps and potholes in the road, but a milestone for me was to get the staples removed. The doctor earlier put up photographs of the two types of scar that you can have. I had the hockey-shaped one, although you can hardly see it now after a few years, which was great. Unusually, I was offered if I wanted to keep a couple of staples as a memento, but not surprisingly, I declined the opportunity. So the pain from my stomach muscles gradually reduced, but continued because it was a huge operation to go through. And the medication that I was on for pain relief got gradually reduced as well as things improved. Felt better every day, not just the recovery from the operation itself, but also from relief from the symptoms that I had previous to the transplant. So things like the jaundice, the lethargy, it was all disappearing. It was, brilliant for me, absolutely brilliant. I was quite an active person before the transplant, and to get some of that energy back again was brilliant for myself. I was visited from a dietitian who was absolutely tremendous. The physiotherapists made sure you were mobile enough and active enough, because you've got to go home at the end of this and you've got to be able to do that, look after things. The social worker, as Fiona has just described, just superb, and they liaise with a local social worker. I don't live in the area where the hospital is, so the local hospital to myself and my GP and the local social workers were all informed of what I'd been through and what was expected of them when I got home. So the local social worker put in place things like a handrail in the bath, a handrail on the steps outside the house. I had a frame for the loo to help me get up and down on it. It was really good, lots of good stuff I'd never thought of. A bed lever to help me get in and out of the bed and to balance when I was getting my clothes on. I'd never thought of it before, but it was tremendous, and it really was good. Can't fault them. It really was good. And from the pharmacist as well. The pharmacist was good in that they liaised with my local GP, so that it was no surprise to them when I started wanting the medications that I was on when I left hospital. Never had an issue with that, really. And when I left hospital, I was given at least a week's medication until the stuff at my local GP kicked in, and that was great. So big shout to everybody in the hospital. Really, really well done. The journey after I was discharged was a little bit up and down, as I said before. A couple of potholes on the road to recovery. I had a restriction in my bile duct, which necessitated me going back into hospital again just for a few days, and I had a stent put in, and that resolved the issue. It was a bit worrying at the time, because you think the worst. You think, oh, problem, my liver's going to fail. It's nothing like that at all. These people in the hospital know exactly what they're doing. They've seen it all before, and they knew exactly what the treatment was. And for myself, more importantly, they knew exactly what to say to me to describe things that were happening and what they were doing. I like to know what's going on. I like to be a little bit in control. So that was really, really good. Again, another booklet from the hospital about going home. Very good information there. And I believe every transplant location in the country has their own little booklets that give you all that information, which is tremendous. So that was it. I continue years after the operation now. I continue to, I'm more or less stable, but I try and get out there and do as much activity as I can. I still look after my diet. The fact that I had non-alcoholic fatty liver disease in the first place, as it was described to me by my consultant, meant that I was part of the problem. But from then on, I had to start being part of the solution. So I feel a debt of honour to them. And that's been my mantra all the way through this, to be part of the solution, not part of the problem. So if I can give anybody any advice, I would say, if there's any support that's offered to you, take it, welcome it with open arms. It's there for a reason. It's there because you need it, and you will accept it, the need for that as you go through this process. Don't forget your family. They're going through this at exactly the same time as you, and it's just as frightening for them as it is for yourself, and in some cases more so. It affects their family, their lives in an extended way. If you think about going back to work, if you can go back to work, everything changes. The whole thing changes. So the quality of life after my operation is immensely better, immensely better. Still have issues from time to time. I'm still monitored. After my transplant, I went back weekly, then monthly, 2 monthly, and I'm on 4 monthly at the moment. They're still monitoring things. And if I need anything adjusted, like my medications, then they can be done. During the COVID revolution, that's the right word for it, a lot of the clinic appointments for people that are more or less stable have been done through online using Near Me, which have been good, brilliant. But nothing like going back to face-to-face meetings. The one thing that's helped me hugely since my transplant has been involvement in the British Liver Trust support meetings, both for myself, and if some of that information and my experiences have rubbed off on anybody else, then that's just brilliant as well. It was something that I didn't have before I went into hospital, was I felt enough information about different types of liver disease and other people's experience. I've gained that hugely since then. So thank you, the NHS. That's it. Look forward to the questions and answers. So back to Amy and Kenny. Okay.
Thank you very much, Murray. That's a brilliant story, and I'm sure many patients and family members in our audience as well can relate to a lot of the things that you said there, a lot of the points that you made, and also I'm sure that your story will inspire people who are currently waiting on the list as well. So if everybody can turn their cameras and microphones back on, we'll now move on to our Q&A session. And we can see there's been a load of questions coming in today. We have a whole lot of questions. So unfortunately, I don't think we'll be able to answer them all because we're going to run out of time, but we will get to as many as we can. Thank you very much. So the first question I was going to ask was for Dr. Appleby. Hello, sorry. I'm going to actually combine a couple of questions here. So we've had a couple of questions asking about driving and when people can drive kind of regularly post-transplant. I'd imagine that's a kind of individual thing as well. But also I've had a question about people post-transplant coming to appointments, coming back to the hospital. If they live a large distance away and perhaps don't drive, what are the options for these people to get in and out of hospital?
For patients that don't drive, in most cases, we're able to facilitate hospital transport. It's a question we get asked a lot. Definitely at Leeds, we can organise hospital transport, but bring that up with your own clinician when you see them in the pre-transplant clinic. With regards to driving, it's absolutely individual, especially if you've had to have your driving licence suspended previously because of hepatic encephalopathy. So in the post-transplant period, you'll have to reapply for your licence from the DVLA. But if you are just not driving because of recovering from major surgery, we would say probably it's very individual. It's how you recover. But for most surgeries, we say sort of review it at about 8 weeks. But that's something to discuss with the surgeon who will see you immediately in that immediate post-op clinic setting. But probably to look at it from about 8 weeks.
Thank you very much.
The second question I'm going to have for Louise, if that's okay. I'm going to do similar to Kenny because we don't have much time. I'm going to combine two questions together for you. So the first question that came through from somebody was, what happens if your brand of immunosuppressants is changed? So I know there's been a few people change from tacrolimus onto Adaport. Is that something that they should worry about, or is that something that's quite normal? And the second question is about vitamin D. So we get lots and lots of questions about, should we be taking supplements for vitamin D, and what is your kind of response to that?
Yeah, so the first part, so in terms of switching between tacrolimus brands, so if that's been done through your liver transplant centre, like it's a plan thing, like we're switched for whatever reason, for example, twice a day to a once a day preparation, that's fine, as long as it's so it basically needs to be under the as long as it's been done under your transplant centre, and normally you'll need increased monitoring initially to make sure that the switch is okay. But if it's just your GP or your community pharmacy is giving you a different brand and it's not something that you're aware of, then definitely question that. And because basically different tacrolimus preparations get released differently in your body, so they aren't interchangeable. For your mycophenolate, azathioprine, and any of the others, then that's absolutely fine. Cyclosporin, the same rules apply in terms of it's a brand-specific medicine as well, but there's not the same number of brands available of cyclosporin, so it's usually less of an issue. and the second bit was about vitamin D. So vitamin D is I guess it's like an exception to our herbal medicines rule. So yeah, no, I guess it's not really a herbal medicine, is it? But yeah, no, we definitely recommend, like, vitamin D is absolutely fine, and in general it's something that we would recommend supplementing anyway, especially if you're on steroids. And so yeah, vitamin D is fine.
Brilliant, thank you, Louise. Fiona, I've got a question for you, so I'll come to you next. So there's been a question come in, Fiona, about what happens if somebody's living by themselves and they're going through the assessment and going home. So what is support is available for somebody who is going through this by themselves or might live alone when they get home?
Okay, so obviously the support there starts from the point they come in from for assessment. I mean, that's, you know, that would be identified, you know, before they even went in the waiting list. And, you know, support would be put in place with local services to ensure that that person was supported when they went home, whether that may be practically with having a home OT assessment be carried out for aids and adaptations such as rails, mobility aids, you know, bathing support, you know, stuff like that. But also emotional support as well. You know, we can, you know, put in touch with befriending services. But actually, if somebody was going home on their own and they didn't have any emotional support, practical support is easier to get to put in for somebody, right? It's a call to local services, and that will all be that, you know, that will be arranged. Also, if they're in and out their local hospital because they're quite unwell, it's very likely they've already got, you know, services in place. But regarding emotional support, if they're on their own, that's really important. And I would, if I had assessed them and they were on the list, I would make it a priority of mine to be supporting that person on a weekly basis, a couple of times a week, a phone call, get them linked in with the support group ASAP. You know, if they're not willing to, or they don't want to do the online stuff, pass on your details, Amy, or the British Liver Trust details, because some people just want one-to-one support, which is, you know, understandable, especially while we're all online at the moment. I think when we get back to face-to-face, it will be easier. But definitely, you know, nobody, if they're on the waiting list and they're on their own with nobody around, they wouldn't be left on their own, because I can only talk from where I'm coming from in our unit, but they would definitely not be left on their own. It would be, you know, up to me to sort of make sure that they were supported, and practically their local services could do that. Also, I would link them in with other groups that you run, not just the Living on the List group, but, you know, depending on what type of liver disease they have, whether it's PSC, so the PSC support, NAFLD support groups, young persons groups, you know, there's loads of different things. It's maybe more difficult if the person's been listed due to addiction issues, so that's even more important to get them linked in with people so that they're not isolated. And I suppose an example we've seen of this has been with COVID, when even people who actually maybe do have support and friends and family around, but actually live on their own, which many people do. You know, not everybody's married or in relationships, or, you know, many people do. I think with COVID, this really highlighted the need for support emotionally for people at home, and ensuring that people don't slip through the net and become socially isolated in any walk of life, but especially you know, post-transplant and while they're on the list. So yeah, we do all we can to make sure they're supported and not slip through the net, and that comes from identification from the minute they come in for assessment, which is normally picked up by the coordinators, to my assessment, to ensuring that they're followed up at clinic, and phone calls as and when needed. Just as much as they need, we'll tailor the support to their need.
Brilliant, thank you, Fiona.
Yeah, so Murray, we have a couple of questions that some are a bit kind of more technical. So again, I'm going to ask you to cover more like your kind of top kind of tips essentially as a transplant patient and somebody through the other side. I mean, just like the key things, the key messages you'd like to get across to people who are waiting or who have, you know, just had their transplant or just in the recovery stage. Is there any key messages you'd like to get across to them?
I can only speak for myself. As I said earlier, be involved as you can, get as much information as you can, but be aware when you go into hospital, it's time to be a passenger in your journey. Let other people do the driving and accept all the help that's given to you. And you may think you don't need it, but it's there for a reason. And people like Fiona coming along from social work department and arranging things in your home, making sure that you're going to be okay, giving you advice on things like financial issues, like getting PIP payments, things, you know, stuff you'd never think about before, but it's so essential and beneficial to you when you leave the hospital, not just for you, but for your family. Don't forget your family. Bring them along the journey with you. They're going to go through it, and they'll be there for you if you've got them when you leave the hospital as well. So don't forget your family. Bring them along the journey with you. One of the other things I found very beneficial was looking after my medication. When you leave hospital, you've got bag filled of tablets, loads of them. And at the beginning, I was taking them at different times of day, and I was forgetting to take some. I was taking too many of them. It was a myriad. There was so many of them. And I found getting an app on my phone, I think someone mentioned earlier, Medisave. I've got that app, I still use it to this day. It tells you actually not just when to take your tablets, but it gives you information about the tablets and the medication itself. And it reminds you, and you can type in the dosage that you do, and if you've taken it or not, you just tick it into a little box. So that's really helped me. That app has been brilliant for me. Someone else asked about holidays abroad. We were told not to go abroad for the first year, which was fine. Didn't really feel like it anyway. And since then, COVID came in, so I'm not really had the opportunity to go abroad. But we looked into holiday insurance, and it was surprisingly easy. It was a company called, I wrote it down actually, All Clear Travel Insurance, and these were recommended by British Liver Trust, along with 3 or 4 others as specialist medical travel insurance. And I thought the insurance would be through the roof, and it was a little bit more expensive, but it wasn't hugely so. So I was quite encouraged by that. So yeah, those and many other tips. Join our support groups.
Yeah, I think that's a great message, to be honest, to end on. Really, we're going to have to end it here because we're running a little bit over, but I think that's a really good message to end on, that there is support out there for people, and if you get offered support, or if you can go look for it, really grab it with both hands, because it's a really big operation you're going through, and it's vital there at the end of the day. So pardon me, I'd like to just thank everybody again for all our speakers today. They've been absolutely fantastic. Everybody's input's been so welcome. Thanks to all the people who attended as well, coming along here, spending your time today with us. That was fantastic. This webinar will be available for you on our YouTube channel, I think soon enough, within the next few weeks at least, I think. And I'm now just going to pass you back over to Amy, who can talk to you a little bit about British Liver Trust support that we have here available for people on the transplant list, and those post-transplant as well.
Thanks, Kenny. I think a lot of the support services that we run has been highlighted already by a number of our speakers. So again, a massive thank you to everyone for joining today and getting involved. I would like to point out some of our main key services for patients that we are there to support you with. So we have got a nurse-led helpline, we have our virtual support groups, and we've got plenty of patient publications available on our website. We'll do our best to send around some information to everybody who's joined today, so that'll all be in your email information after the webinar. But do in the meantime, have a look at our website, and do try and sign up to our newsletter if you haven't signed up as of yet. But again, massive thank you for everyone on our panel today. It's been absolutely great getting the expertise from both the clinical side and from the patient as well. So thank you so much, everybody. And thank you everybody at home for joining us this afternoon. We hope that you found it informative and you enjoyed it, and we hope to see you all again soon. So thank you very much, and enjoy the rest of your day.